Dear colleagues, distinguished speakers, ladies and gentlemen, welcome to the latest research of COVID-19 control and prevention in children, a platform where health experts can share their insight on the COVID-19 handling. Please allow me to introduce myself. I'm Dr. Yiming Shao, Chief Expert of the Chinese Center for Disease Control and Prevention. I will be a moderator for this important symposium focusing on children. We will have 5 speakers in the session. Each speaker will present about 25 to 30 minutes, and then we have a follow-up questions. And after that question, we will move to the next speaker. Our first speaker is Dr. Michael Kwan, head of the Pediatric Infectious Disease Unit, Princess Margaret Hospital, Hong Kong. Dr. Kwan, please, the floor is yours.
Thank you. This is my honor to be invited to share my experience. So my talk about the disease burden of the infection, especially this Omicron among the children in Hong Kong. So I'm the pediatric infectious disease consultant of the Princess Margaret Hospital in Hong Kong. And so this is more or less the trajectory of the COVID-19 infection from wave 1 to wave 5 in Hong Kong. You can see from wave 1 to wave 4, we are more or less doing quite good. But however, in wave 5, there's a very high upsurge of the infection since mid-February in Hong Kong. So this is more or less the latest figure of the notifications and also the vaccination rates in Hong Kong. You can see, unfortunately, from age 0 to 17. In Hong Kong, the pediatric age group range from 0 to 17. We got 8 deaths already from the COVID-19. And this is the number of the unvaccinated populations amongst the 3 to the age 19, among 200,000 still not vaccinated. So this is quite a lot of good news for us. So you can see this is a breakdown. From age 3 to 11, only around 65% of the children got vaccinated. However, amongst those adolescents from 12 to 19, 97% now got vaccinated. And for your information, the school in Hong Kong just start to resume the face-to-face teaching 2 days ago. So this is what we worry. We worry that under this low vaccination rate, there might be another outbreak among the school, among the students, what we call the 6th wave in Hong Kong, maybe several weeks later. So symptoms of the COVID, all of you know, but among the Omicron outbreak, we observe those children, they got very marked fever and also sore throat. This is a very main symptoms in the Omicron infection. And they got a very high transmissibility, and they also got some special symptoms. I will talk about this later. And the R0, you can see from the study now said to be range from 10 to 12, which is different from the Delta, only around 7 to 8. And we already know this from last November that the Omicron actually caused a very huge infection among the small children, especially 0 to 5. And now we can see this in Hong Kong. Actually, this infection caused a very huge infection among children, especially the young children. And also, we receive news, especially from Singapore, that they have many children suffer from the condition called the multi-system inflammatory syndrome, after the COVID infection. And I would elaborate this more. Actually, we are seeing this syndrome 2 weeks ago in Hong Kong. And also, we got evidence that Omicron spread by airborne routes, which is a different concept, because previously we thought that the COVID-19 only spread by the droplets or the contact route, but now we are seeing that the Omicron can spread by the airborne route. And also, I mentioned before, we have fatal cases among our children and also adolescents. So this is some mild cases. We encounter some mild dermatological manifestation of COVID, some urticarial lesions after the COVID infection. And also some cases, they got the anosmia and also ageusia. This paper we published in the PIDJ some time ago. And I still follow up these patients, and some of them, their anosmia persisted now already more than 12 months. They lost their sense of taste or sense of smell up to 12 months after the infections. And also some cases of pneumonia. You can see in this adolescents, got a right lower zone haziness and eventually, fortunately, recover after hospitalizations. And also, we published a case of the COVID toes and in an adolescent boy in Hong Kong Medical Journal. And this boy got a painful, very tender toe lesions, and after the COVID infections, and fortunately, eventually recovered. This is another patient with the COVID toe after the COVID infections. But most importantly, we saw many neurological complications in children in COVID during this Omicron wave, and which we never encountered before in the wave 1 to wave 4. And it is a very severe neurological complications arising from the COVID infection. And especially in this outbreak, which is a BA.2 variant. And we published a preprint in Lancet, and which is widely reported all over the world, and regarding the increase in the mortality and also complication from this BA.2 variant. And we analyzed around 1,100 children admitted to our hospital during February. 80% of them range from 0 to 5 years of age. And 1.8% require pediatric intensive care unit admissions, and 8 of them require mechanical ventilation. And 11 of them require oxygen therapy. And 15% of them got neurological complications, and 5 of them developed encephalitis and also encephalopathy after the COVID infection. And this is very, very alarming, because this never observed and never encountered during the previous wave 1 to wave 4 of this COVID pandemic. And so we compare the Omicron infection with influenza. So how about for example, the mortality or other parameters? You can see the mortality, the risk ratio 2.7%, and other like the PICU care 2.1, and the oxygen care, the relative risk 2.3, and also regarding seizures, febrile seizures, and seizures with fever and encephalopathy, they all markedly increase compared with influenza and with a p-value of significance. How about compared with para-influenza? The same. Regarding the mortality and neurological complications, seizures, febrile seizures, and seizures of fever, and encephalopathy. So this paper, we want to illustrate to parents that never compare the COVID-19 infection with flu or para-influenza. It is not an ordinary flu. It is a severe infection in children with complications and also can with mortality. So this is what we call the acute necrotizing encephalitis, we already have at least 2 children died of this condition. This condition presented with change in consciousness and focal neurological deficit with vomiting and also with a prolonged seizures. And also other neurological complications we encounter, including the ADEM, the meningoencephalitis, or some patients have hemorrhagic stroke or acute ischemic stroke. And also other neurological symptoms, including the anosmia and necrosis I mentioned before, and the headache, and also seizures. And people now also worry about the long COVID, about the brain fog after the COVID-19 infections. So after I talk about the neurological complication, how about the respiratory complications? Among children, we encounter many children, they admitted with these conditions. They with the severe upper airway infection. This baby suffer from a croups. You can see the hoarseness of voice and also with the breathing difficulty. This is a condition what we call the croups. In Chinese, the sea housing. And after mentioning the acute complication of the COVID infection, the neurological complication, and also the upper respiratory complication, this condition is now a concern in Hong Kong. This is called a multi-system inflammatory syndrome in children, which happened 2 to 6 weeks after the SARS-CoV-2 infection. And we treated 1 case at the wave 2 in Hong Kong, and we reported this case in the Hong Kong Medical Journal. But after the outbreak of Omicron since mid-February, 2 weeks ago, we start to see many cases now keep on reporting in Hong Kong now. And so this is the case we reported to the Hong Kong Medical Journal. We treated 1 case of this MISC during the wave 2 in Hong Kong. So this boy presented with fever and lymphadenopathy, the conjunctivitis, rashes, red and cracked lips, and also strawberry tongues, and what we call the MISC, around 4 weeks after he recovered from the COVID infection. And you can see this is the red eyes and the conjunctivitis. And at that time, he got a very raised inflammatory markers. This is the cytokine, the interleukin-6, and also indicator of a cardiac injury. We measure the N-terminal pro-brain natriuretic peptide level, the NT-proBNP level. And how we treated this boy, we treated him with 2 doses of the IVIG, and eventually he recovered with subsidence of the temperature and also subsidence of the pulse rate. And eventually he recovered with no bad sequelae. So this is the multi-system inflammatory syndrome, including fever and multi-organs involvements. So after this under this Omicron outbreak, this data only at early April, we noted 15 cases, and 9 boys and 6 girls, range from age 3 to 11, and tell you all of them non-vaccinated, and only 4 received vaccinated, but we treated them unvaccinated because their vaccination within 14 days and before their COVID infection. And 2 received the Sinovac and 2 received the BioNTech vaccine. So none of them received the vaccination. And after the COVID infection, they developed this MISC. But I can tell you at this moment, I'm talking to you, in Hong Kong, we got more than 20 cases already. And so I just told you that we keep on receiving reporting of this MISC every day. So there are symptoms including fever and the inflammation of other organs, including the gastrointestinal system and coagulation problem, and also the heart. Some of them requiring allotropes and also with pericardial effusion and requiring PICU care. So this is a clinical sign with the generalized rash on the body. And also some of them got a erythema or induration of the BCG scars. So this happened 2 to 5 weeks after the COVID infection. So the definition or the criteria of this in Hong Kong, including the children 0 to 17 years old with evidence of the COVID infection, fever longer than 24 hours, and with 2 or more organs involvement, including gastrointestinal system, hepatitis or pancreatitis, central nervous system, and respiratory system involvement, and dermatological involvement, and coagulopathy, cardiovascular system involvement, or renal involvement, and also evidence of inflammation and raised in any anti-inflammatory markers, and also those infection or inflammation cannot be explained by other pathogens. So this is I can tell you this is a upsurge of the MISC in Hong Kong. So this is the approach of our treatment. We would record the clinical sign and symptom and perform laboratory investigations, and many of them require supportive care like fluid, vasopressor, and ventilatory support. And we would document the cardiac involvement by ECG and perform imaging for the heart and also for other organs. And some of them need anticoagulations, and also we need to consider immunomodulations. So because this is a very important conditions, we organize a case sharing and discussion next Wednesday, lunchtime, Hong Kong time, 1:15 to 2:15, and with presentation from various hospitals in Hong Kong. I cordially invite all of you, please join, and we can share our experience, and we would like to discuss on how to manage this condition, and also especially increase awareness of this condition amongst doctors in Hong Kong and also other parts of the world. And especially we would like to know how to recognize this condition early, and regarding how to best treat this condition. And especially one question I have in mind is whether this patient can receive vaccination after this MISC. This is what our discussion would like to arrive at the conclusions. So how about the mortality cases in Hong Kong? This boy unfortunately died after the COVID infection, and in Hong Kong, the doctors, we advocate the parents to bring the children for vaccinations. And we have a mortality and severe COVID case review panel, expert panel, led by Professor Yulong Lau. And this is the report we released to the public and in early April. And amongst these 8 deaths in the public hospital, we attributed their cause. 3 of them died from COVID, and 3 of them COVID-19 as a significant contributing factor resulting in the death. And 2 of them are still waiting for the biopsy or the postmortem results. So this is the message we deliver to the public. Among the children died, 8 children died, 4 actually eligible for COVID-19 vaccination. However, the vaccination was not given. And among 26 in severe or critical conditions, 12 of them eligible for COVID-19 vaccination. However, the vaccination was not given. So we strongly advocate the parents to bring their children for vaccination to avoid this mortality and also severe or critical condition in Hong Kong. And these are the symptoms of severe infection, like the convulsions more than 30 minutes with change in consciousness, and also severe respiratory distress. We also issue some warning signs for parents. When they encounter this warning sign, they need to bring the children to the accident and emergency department immediately. For example, when have deep breathing difficulty and noisy breathing and blue lips and chest pain, a very fast heartbeat and decrease in the conscious level. So this is a conclusion, and to advise the parents to bring their children for vaccinations. And because we have a very shortage of the hospital bed, the medical society issue advice to parents and how they take care of the children at home. And these are all issued in different languages, in Chinese and also English, and they can access by QR code and teaching them how they can monitor their children at home. And we just received the news from Taiwan. They have a 2-year-old boy and died from COVID, and this report issued on 19th of April. And 2-year-old boy, and also with the acute necrotizing encephalitis, and due to COVID. So another message is that do not treat COVID-19 as an ordinary flu. They can have a severe neurological complications. In Hong Kong, we got 2 vaccines. We got the Sinovac and also the BioNTech vaccine. The Sinovac vaccine can be given from the age of 3 onward, and the BioNTech vaccine can be given from the age of 5 and onward. And this is the summary we deliver to the Hong Kong parents. We analyze the vaccine, the different platform to them, and also their different immune response to the spike protein and leukoprotein, and also the different regime, and also specifically we explain to them the different T-cell response to the parents. And one message we need to advise to the parents is that the mRNA vaccine, they will cause the myocarditis, but we try to avoid this condition by lengthening the duration of the 2 doses, now up to 8 weeks, to decrease the chance of the myocarditis among the children and the adolescents. So this is the vaccination regime in Hong Kong, and we listed this in different age group, and also for the immunocompromised person. For the immunocompromised person, we give 4 doses, and for the children with normal immunity, we give 3 doses. This is a research by Professor Yilong Lau, and showing that given 3 doses of the Sinovac vaccine, they're able to mount the Omicron neutralizing antibody, and this is the same as 2 doses of the BioNTech vaccine. So this important message we deliver to the public, explain to them both vaccines, they are effective in protecting against the Omicron infections. Also, parents worry about the allergy. Some of them, they worry about allergy and they don't bring their child for vaccinations. And this recommendation issued by 4 medical society explaining to them, even their children got an allergic history not related to the COVID vaccine or component, such as any drugs, food, insect venom, inhaled allergen, even asthma, allergic rhinitis, eczema, or chronic spontaneous urticaria, they still can bring their child for COVID vaccination without consulting an allergist. So this also want to increase the confidence of our population to the COVID-19 vaccinations. So I thanks for inviting me to this talk, and this is the end of my talk. Thank you.
Thank you very much, Dr. Kwan, which gave a very comprehensive report on the multi-system inflammatory syndrome. And also, we thank you for setting up the platform of sharing this important syndrome with the world. Is there any questions? Immediate questions? I have one. What is the reason we saw in the 5th waves of this syndrome in children? Is that because we have more cases and they become fun, or is there because of the neural system of children is not, still in development, is more vulnerable? Is there a variant of the virus? Or could there be other viral co-infection? So what's your observation on this?
And thank you for your question. We believe there's no other virus co-infection because amongst our children, all our tests we performed in these several months, only COVID-19. We didn't identify any other viruses. But we believe that mainly because our children, they are really well protected because all of the population wear masks, they got very good personal and environmental hygiene. They have no chance to encounter other coronavirus. They have no cross-species immunity. So they actually never encounter any coronavirus before. So this is why when the Omicron virus come into Hong Kong now, and they got the so severe infection, and also especially among our young children, they got an immature immune system, so leading to the sudden upsurge of the infection, and some of them got a severe complication. And we really believe that this Omicron virus, they can attack the neurological system, leading to this acute necrotizing encephalitis and other neurological complications. And most importantly, because of the denominator effect, the increase in the huge number of infection. So subsequently, the MISC, the multi-system inflammatory syndrome, the number getting so high recently. Yeah, thank you very much.
Thank you for your discuss. And there's another question from the audience. How was the patient's platelet count? Is that normal or not normal?
You mean their past health?
Platelet count. The clotting factor, platelet.
Oh, this is a very good question. Thank you very much. And for our patients, I observed that most of them got quite a number of them got a deranged clotting problem, and especially they got a very markedly raised D-dimer level. And so we are thinking that actually we are giving quite a number of them for example, the aspirin and also the low molecular weight heparin in the 5th wave as compared to the past 4 waves.
Thank you.
Thank you.
There seems no other questions, so we've thanked the question again.
Thank you very much.
And people who are interested may follow the next Dr. Kwan's symposium. He has announced during his talk. I will introduce our next speaker, Dr. Rafael Aros. He's the head of the epidemic department of the Ministry of Health, University de Desarrollo. His talk is the real-world analysis of effectiveness of inactivated COVID-19 vaccines in Chile. This is with over 10 million subjects, a large data analysis. Dr. Aros, the floor is yours.
Thank you, Dr. Shao, and thank you everyone for inviting me to present. Super happy to be here sharing our experience with you. So I'll share my screen now. Okay, so we've been working with vaccine effectiveness for the last year and a half. So I'm gonna try to give you an overview of the approach and what we are doing actually today, going from primary series in adults to children and Omicron. So I'll try to give you as much information as I can in this short presentation. Are you seeing the presentation, right?
Yes.
Yeah, so this is overview of the vaccination program in Chile. Chile is a small country in the southern corner of South America, right? We put our first dose of Pfizer vaccines by the end of the year 2020, but actually our main vaccine for the mass vaccination campaign was here in February 2, 2021, and was Coronavac. So at that time, we started to vaccinate the elderly and people with medical conditions and those that were most at risk, like medical personnel and professors, using Coronavac. And basically within 2 months, we roll out more than 4 million doses of Coronavac. Then we approved CanSino's Convidencia vaccine, and then June 22, we approved Pfizer's for children between 12 to 16. So we started vaccinated children or adolescents actually by the end of June 2021, very slowly at the beginning. And then on August 11, we started our vaccination campaign with first boosters. Those were heterologous and homologous boosters, as I will show you later. And then on September the 6th, we approved for emergency use Coronavac below 12 years old. So we started to use Coronavac for children between 6 to 12 since September. At that time, we also used Coronavac for the group between 12 to 16 because there were delays in the arrival of the Pfizer's vaccine. So many people between 12 to 16 also received Coronavac. And then so we started here by the end of September, it was approved here. And then on December the 6th, we started vaccinated children between 3 to 5, it should say there, sorry. And it was very important that because coincidentally, we reported our first cases of Omicron like a week before the date of the rollout. So all the rollout in this age group between 3 to 5 years old, which exclusively have received Coronavac, occurred or enclosed the Omicron period. And now we are in the middle of our fourth dose or second booster campaign, which is mainly with Pfizer. So this is, again, an overview of the situation in Chile. So you can think about our vaccination as a test for the vaccine against different lineages of the virus. So this is the world. Chile represents the same locally. So you can think about Chile. This is our epidemic curve. First wave, this was a second big wave. Third and fourth, this was the original virus. This is mainly Gamma or P1. This was Delta. We had a very, very low Delta wave, a mild Delta wave, and this is Omicron, and we are here right now. So we are having few cases now. And as you can see here, this is the Omicron period that encloses this wave. This is Delta that encloses this wave, and P1 enclosing this wave, and this is the original lineage. But we started vaccinating people like here. So primary series that were mostly Coronavac, almost 12 million people received the full scheme since starting on February the 1st or 2nd. So that evaluation talks about P1 or Gamma, okay? Then the homologous booster started here just before the Delta wave, which, interestingly was very mild. So there might be something with the booster protecting us against Delta. So the vaccine effectiveness that we assessed here, like here, basically explain how vaccines behave against Delta. And finally, here, with the children vaccination, we can evaluate Coronav for Omicron. So we're going to be able to see how Coronav works over time against different variants, and again, and across the age spectrum. We have experience with AstraZeneca and also with Pfizer, and now recently with Moderna. But the focus of the talk is Coronav, so I'm gonna just refer to the inactivated vaccine from Sinovac. So what do? We at the Ministry of Health, we built up a huge administrative cohort. So in Chile, you have one unique number for identification that we used for basically everything. So we can have access from the Ministry of Health to different administrative data sets that allowed us to build up this cohort. The name is VCOVID. So FONASA is the national health insurance that provides healthcare to 80% of the population. So we have most of the people living in Chile within the cohort with very good metadata. We have social demographics, we have comorbidities, and also we have another data set that reports daily to the central authority regarding all the hospitalizations in the country and all the ICU admissions, not only COVID, but we can ask the hospital whether subjects admitted to the hospital or the ICU were due to COVID. So it's not just having a positive test. So we can ask the data set about the test, but also about the diagnosis. So that's a positive thing. And also we can explore other outcomes here, like very general ones like death or admission to ICU or using mechanical ventilation. But if we want, we would be able to be a bit more granular for answering specific questions. And also we have a vital statistics department that tell us about or confirm our death statistics, and also very strong national surveillance system for SARS-CoV-2, in which we test actively with mainly PCR, everyone with symptoms, and we have a strong also system for looking for asymptomatic infections. So we think we are being able to capture a significant number of the cases of COVID that are occurring in the country. All these data sets report daily or in real time, like the National Immunization Registry, to the central level, so we can make sure every day about the dynamic of the response. So basically, from all these data sets, we built up this cohort. To do this, took us like a lot of times, like a 7,000 line code that has to be run every time we want to make sure that everything is correct, that it's a very rich resource. So how did we think about the study? So it's a cohort, right? So we have a predictor which is being exposed to Coronav. We can think about the primary series, we can think about third doses, we can think about 4, 5, 6, but it's always some kind of exposure. And the comparator can be none, right, unvaccinated, or 1 or 2 or 3 or other vaccines. So we can so that's the first part of the cohort. Then we have the outcomes. We usually look for infection, which is a positive test, and also look for symptomatic infection, also hospital admission and ICU, and death. We only used confirmed death and cases, trying to avoid the noise that introduced the probable cases. Then we model results, and we adjust for confounding in the model, and we have access to these covariates. If you want, we can discuss. We have a very good list of comorbidities, and we have very granular data regarding where the people live, where they come from, income, age, and sex, and other things, but these are the most important ones that we control for in the model. Then we include up to the study, because, as I've been saying, we've been doing this repeatedly with different questions, but basically always the inclusion criteria is being an active insuree within the national health insurance and being part of the age group that we are interested in. We always exclude cases prior to the initiation of the study, either confirmed or probable, and we also exclude any other COVID vaccine prior to the date of interest. And then the statistical approach is, trying to summarize it. What we do is we estimate the hazard ratio between the two groups. Let's think about primary series, which is the most simple one. So we estimate the HR within those vaccinated against those unvaccinated. Then we used an extension of the Cox proportional hazard models that allow us to control for time varying variables, and also it has in its heart the calendar time. So we control for calendar time in the model, and then we adjust using IPW, inverse probability weighting, as in marginal structural models for trying to control for complex data covariates like 8 and others. And if we want to, this is just a scheme trying to show you why we have to use the extension of the Cox model for looking for causality, and this is the reason. So here's a case, okay, a COVID case, and this person received the first shot after being a case, and the second one well after. And if you think about this subject shouldn't be considered a vaccine failure, right? Because he has COVID before being vaccinated. In a regular Cox model, this would be a person that received the vaccine and had COVID and would be considered a failure, and it is not. And on the contrary, this is a subject that had COVID here and got the vaccine here and here, his second dose. So this is actually an example of a vaccine failure, and the extension of the Cox model allows us to control for this. So everyone in the follow-up contributes to the unvaccinated population during a particular time, in this case from this date to this date. Then this guy is going to contribute to the one dose group here, then to the fully vaccinated here, and he has a case here. So this is a failure of the second dose. That's the general structure of the studies. Now let's go to the interesting part, results. So this is our first work. This is early effectiveness of Kononovac primary series. This was a study that was published at the New England Journal. Was very provocative because at that time, we were in the middle of a huge outbreak of P1. So everyone was saying that the vaccine didn't work. And actually the contrary, that's why, methods and cohorts are great, because it was the opposite. So if you can see here, on a cohort of more than 10 million people above 16 years old that received exclusively 2 doses of Coronavac, the effectiveness against symptomatic disease was almost 66%, 88% against hospitalization, 90% against ICU admission, and 86% against death. This is a bit lower than the other outcomes, because probably some people died at home because, limitation of the medical efforts for several reasons. So, but in general, we had these great numbers, and there are several papers following this one showing the number of deaths that were avoided or prevented by using this vaccine. Then on August 11, 2021, we realized that doing the follow-up of the study that I'm not showing you, realized that the effectiveness against COVID was, going down, not just for Coronavac, but also for Pfizer's vaccine. So we decided at some point that we weren't, willing to have a new wave as severe as the P1. So we relied on boosters, and by program, we were planning to vaccinate children and adolescents with Coronavac. So we used mainly AstraZeneca for the elderly, Pfizer for the people below 55, but we used a significant number of Coronavac for everyone willing to receive a third dose of Coronavac. And the total number of people that received a booster, an homologous booster, was around 280,000 people. So it's a good number for estimating effectiveness. And here I'm just going to show you the effectiveness of the booster dose, again, always 14 days after the booster dose for all the same outcomes. So here you have the outcome, you have the exposure, person days, events, incidence, and the stratified analysis. This is going to be published probably next week at the Lancet Global Health. So you'll be able to see this as a formal paper next week, but now it's accessible by the Lancet preprints. And as you can see here, a booster of Coronavac, so third dose of Coronavac, was 78.8% effective against COVID, 86% effective against hospitalization, ICU admission, again, 92%, and death, almost 87%. And those, so the numbers were great at the level of the infection and COVID. It was lower than Astra and Pfizer's, but the results for the severe outcomes were pretty comparable, most of them within the same confidence intervals. So these results were great, and this is what we saw with the Delta wave, in which this study was done in the middle of the Delta wave. So we think that at least at the population level, Coronavac was very, very effective against that variant. Then third, we have a first evaluation of the effectiveness of Coronavac primary series in children and adolescents. Here I'm showing you individuals from 6 to 16 years old. During the transition from Delta to Omicron, so it's a mix, more Delta than Omicron, and the numbers are here, super good for avoiding COVID, 75%, hospitalization 90%, and ICU admission 94%. There were only 2 deaths, and the death occurred in the unvaccinated population. So you can say that it was 100% effective to prevent death. But you know, it's not possible to estimate it's possible, but that doesn't make any sense. So we are not including that outcome in the tables. 4, and this work is going to be published in Lancet, in the Lancet Regional Health, probably within a month or so. 4, this is the study that we did in the younger children, those that started their vaccination by the beginning of December last year. So they've been receiving vaccines for the last 4 to 5 months, and it occurred during the Omicron outbreak. So this is mainly a reflection of the effectiveness of Coronavac against Omicron at the population level. And as you can see here, again, same outcomes, COVID, hospitalization, ICU admission. I'm not showing death because there were none. Again, unvaccinated against primary series, person days, allowed events, crude rates. And here, unsurprisingly, protection against COVID wasn't that great, but these numbers are very similar to those that Pfizer have shown, Moderna, and also a bit better than those shown by the UK group working with Astra. And then you have COVID hospitalization, which is again super good number. You have to consider that this group, the baseline risk for being admitted to the hospital or dying or any severe outcome is really low. So for any vaccine to show an effect is difficult. So the way I see this, it's a very good number. And again, for avoiding ICU admission, it was very high. 5, this is a bonus. This is not from my group. This is Hong Kong, and this is I'm using the report published at The Economist because the figures are so beautiful. So you can see here that when the group in Hong Kong studied the effectiveness of primary series or third doses of Sinovac or Pfizer's, there's a very surprising and good news, I think, regarding the second dose and the third dose particularly. So as you can see here, and always Pfizer in the, I think is blue, I'm colorblind, so sorry. And this is Coronav, this is the central estimate, and the rest is the bars are the uncertainty. As you can see here, the differences that you can see in the one dose that we were aware of that, we know that Coronav needs 2 doses at least, were less marked with the primary series. And then you can see that 3 doses of Coronav reached almost the same effectiveness than BNT or Pfizer's vaccine. So this is again a very interesting data. We are considering this study for rethinking about our boosting strategy. Younger people, like people below 30, have more risk for myocarditis, and using Coronavac in that population is very appealing, or any other inactivated vaccine. So again, I'm coming back to the presentation, and so my conclusion is that Coronavac is highly effective for preventing severe outcomes after primary series, homologous boosters, and across the age spectrum, and also effectiveness against severe outcomes associated to infection due to different variants of concerns seems to be consistently high as well. Thank you. I want to thank the China CDC and the COVID mechanism. We're starting now a study that I'm trying to open here, which is going to be an incredible cohort. We're going to be surveilling people at the population level with a more frequent testing, looking for vaccine effectiveness at different levels. And also we are going to gather a cohort of 10,000 people looking for different outcomes, including long COVID. So thank you.
Thank you very much, Dr. Aaron, for your big data and with very important findings for both adult and children. And there's a question. I think your data clearly show that children with 2 doses of Coronavac is a less immune response or protection compared with the adult. You also mentioned WHO has already recommended for immunocompromised older people for use the 3rd dose as a primary series. That means 3 doses as primary series. Yeah. And is there a plan in your country to consider that strategy?
Yeah, it's a very good point. Just for the sake of the presentation, I continue using the primary series for the 0-28 days schedule, but actually we should be thinking about a 3-dose schedule for primary series. But having said that, it's just for presenting the data. But in Chile, everyone goes for a 3rd and a 4th booster. So I'm not sure how should we call it now, like a 3rd dose, 4th dose of boosters. But everyone is going to be repeatedly vaccinated, either homologously or heterologously over time. So yes, everyone is going to receive a 3rd and a 4th dose.
Yeah. Is there a plan for children under 3 for future vaccination?
Children for a 3rd?
Under 3 years. I mean.
Yeah. If that's so, we're eager to know about the study from South Africa and those that are following subjects below 3, because at that moment we're going to start using it.
Yeah. And so since you have the beautiful big data for your country, I saw in U.S. Congress hearing some congressman or senator, they compare the COVID vaccine deaths with the flu vaccine deaths. They said it's like a COVID vaccine in US use. It's like in 10 to 20,000, and for a year, and for flu, it's only 60 to 80 cases of deaths. Do you collect data like that in your country?
So, yeah. So no, because for influenza we have a sentinel surveillance. So it is not possible to estimate for sure based on laboratory confirmed diagnosis the real burden of disease. So probably one of the positive things of the pandemics is that all the surveillance system is going to be upscale. So probably we're going to be able to have that data during the year, but today, no.
Yeah, last question is, how about the protection of the fourth dose?
We're waiting for a month more of follow-up because it's been too few weeks for making sure how it works. But when we are the first sight of the data seems to be very effective, even considering that for the severe outcomes the third dose are still active. So we are seeing values above 85 to 90% for any combination that you can think about. So the message is any fourth dose works, and that includes the inactivated vaccines.
Is there consensus on the interval between the third and the fourth doses?
No, not for sure. We've been very practical, and based on immunogenicity data and our follow-up, we think that 6-month interval it's good. But I have one observation that's ecological, but we started the booster, the fourth dose or second booster in the middle of the summer, and we had our first cases of Omicron before that, and we had a huge Omicron wave, and we have significant number of disease and death in the people above 65 years old, and that people received the booster on August 2021. So my guess is that we were a bit late. We should have been vaccinating people by the end of 2021, but that was like 4 to 5 months after the third dose, and it would have been impossible to convince people to do it.
Yeah. Thank you very much for your excellent presentation. Now I would like to invite our third speaker, Dr. Xiaoqing Liu. Is an associate professor of Yunnan Center for Disease Control and Prevention. His title is a review on the safety data from inactivated COVID-19 vaccine centers. Dr. Liu, the floor is yours. You may have to unmute yourself. We cannot hear you. We can see your slides.
That is okay. Good morning. Now I will share my study about the safety observation of the inactivated SARS-CoV-2 vaccine. It's developed by Coronav. The study is in a population aged 3 years and above. For the vaccine, the Coronav vaccine is get the conditional approval among the population aged 18 years and above. The conditions need to be verified include the conduction of the safety observation in a large scale use. And the second is the discovery of possible AESI and SAE. On July 15, 2021, Coronav gets the emergency use among the population aged 3 to 17 years, or need the safety observation in a large scale population. So during this period, multi-center study among the adults aged 18 years and above in 11 provinces were designed in May 2021 and implemented in June 2021. The trial gets registered already. And the second is as Coronav was approved emergency use among population aged 3 to 17 years in July 2021. So another study was designed on the basis of the multi-center study, carried out the 9 of 11 provinces. These two studies follow the similar study process and collect the similar data. So our objectives is the first objective is to evaluate the safety of the Coronav among the population aged 18 years and older. This population includes the people with underlying medical conditions. And the second objective is to evaluate the safety among the population aged 3 to 17 years in a large scale use. So based on the above two objectives, we also try to provide the evidence of the safety for immunization strategy of the COVID-19 vaccines. This is the distribution of our study set. In this stats, we can say that the province during this study is from the north to south, from the west to east. So in my province is the Yunnan province. We are the leading institution. We have the 11 provinces. This is the sample size in these two studies. For the adults and the adults, we totally have 121,000 subjects were supposed to be recruited in 11 provinces. In each province, need to recruit at least 11,000 participants who with no less than 2,000 people suffering from the underlying medical conditions, and no less than 4,000 people aged over 60 years. For the children and the adolescent group, totally we try to the sample size is about 27,000 subjects aged 3 to 17 years old. For each province, they need recruit at least 3,000 participants with the number of 3 age group or less than no less than 600. For the 3 to 5 years old, we have the 600 subjects. For the 6 to 11 years old and 12 to 17 years old, is sample size is about 1,200 respectively. The inclusion criteria is people who never received any COVID-19 vaccine or only received at least one dose Coronav developed by Sinovac. The second inclusion criteria is people who aged 3 years and above. Also, the people or their guardians who are willing to sign the informed consent and complete the follow-up. The exclusion criteria is the previous severe allergic reaction to the early vaccines. Also, the people with severe neurological conditions, people with acute disease, and any chronic disease, and several chronic disease. The indicator of the safety observation about is include the solicited local AE. It's about include the pain, induration, swelling, redness, rash, and protest. And the solicited symptom AE include the fever, acute anaphylactics, diarrhea, allergies, vomiting, nausea, and new onset seizures. And also we include the other kind of AE. It's about the AESI for adults and the elders. AESI for the children and the adults is different. Also, we collect the SAE, serious adverse events. The parameter include the primary parameters is include the instance of the AE within 7 days after each dose of the vaccination in all participants. The secondary parameters include the instance of the AE within 7 days, within 28 days, and also the instance of the AE within 28 days after each dose of vaccines in participants of the different group. There also, we have the exploratory parameters. Is include the incidence of AESI after within 28 days after the first dose, 6 months and 1 year after full vaccination in participants and the participants of the different group, respectively. Also, we corrected the instance of the SAE within 28 days after first dose, 6 months and 1 year after full vaccination. It's our procedure and the content. In each research set, we under the using the design and the same the design and the same the real-time information monitoring. We get the informed consent after the subject come to our research set, and also we will to check the inclusion and the exclusion criteria. If the participant is our real subject, we will get the vaccination for this group, the first doses, and after 1 month we will give the second dose. After the vaccination, we will use the real-time information monitoring to collect the safety data. The monitoring, the consent includes the number of the participants, vaccination, and inform the comparison with the provincial system to the vaccination information. And also, we will use the real-time information to collect the 3 level reviews to POV, district, county, city, province, and also if there are any AE, SAE, and AESI were reported, we will to necessary to action for the SAE and the AESI. Finally, we will get the database, and then we will clean up the database and the statistics, the analysis, and the summary report. This is our study progress. In May 2021, we have the plan to get the approval, and also in the next month, we conduct the research in Guizhou, Anhui, Fujian, Yunnan, Chongqing, Jiangxi, and other provinces. And now we totally finished the study of in the adult and the elder, but the study among the children and the adolescent is still update. So now we just have the interim result. Totally, there are 131 participants included in this study. The overall immunization complete rate was 84%. The rate of the adult group, elder group, health group, and the underlying disease group were 86%, 89%, and 87%, and the 87% respectively. There are 30,000 participants included in this study. Currently, is 3 to 17 years old. The overall immunization complete rate was 90%, and there are 89%, 94%, and 85% of population in 3 to 5 years group, and 6 to 11 years group, and the 12 to 17 years group received the full dose of the vaccination. For the age distribution, for the study of the adults and the elders, the percentage of the adults aged 18 to 59 years, or 60%. For the study of the children and the adolescents, it's about the 50%. For the underlying medical conditions, the percentage of the top 10 UMC, underlying medical condition in this study of the adults, and shown in the following figures. With the hypertension of the highlights, hypertension and diabetes, and chronic gastric disease. The incidence of the AE for study of the adults and the elders, and the study of the children and the adolescents was a low level. It's about 3% and 2.17% respectively. Most of the AE occurred among the adults aged 18 to 59 years, and the children aged 3 to 5 years. The most advanced AE occurred after the first dose of the vaccination. We can see the figure that for the second dose is no level. The incidence of the AE among the adults and the children were 2.21% and 3% respectively. The incidence of the AE by age group, more than 80% AE were solicited, with the incidence in adults and the children group is higher. Among all the solicited AE, local AE have the higher incidence. For the two age group, it's the same figure. The incidence of the AE by age group, according to the date, most AE happened within 7 days after vaccination in the both study. After the 7 days, that's only 0.03 or 0.4%. For the population aged 18 years and above, pain of the injection site was the most common AE after the vaccination, followed the physical induration, swelling, and the headache. For another age group, the population aged 3 to 17 years, pain of the injection site was also the most common AE after the vaccination, followed by the cough and the fevers. For the AE grade, most AE were grade 1 in these two studies. The incidence of the grade 1 AE among the adults and the children were more than 20%. Only a few AE group grade 2 or grade 3 in both the age group. For the SAE and the AESI, there are during the study we found that we get 13 death case reports, but all these cases were confirmed as non-adverse reaction. And the diagnosis is by the expert of the community, include 7 cases occurred among the elder and the 5 cases among the adults and 1 case among the adolescent. There are no AESI were found in 2 studies currently. So now the interim conclusion is Coronav show a good safety in a large scale population aged 3 years old and above, include the adults and the elders with the underlying medical conditions. The incidence of the AE were 2.92% among the adults and the elders, and the incidence among the children and the adolescent was 2.17%. Most of the AE were solicited under grade 1, and with pain of the inject site in the most common symptom. Most of the AE occurred within 7 days after vaccination, with the higher incidence of the AE event after the first dose. The interim result was subjected to change according to the final result. So this is the study result show to you. Thank you very much.
Thank you, Dr. Liu, for your comprehensive report on the interim results of the safety study. I have a question for asking for your opinion on the adverse effect. They're less in the people older than 60 in the adult group, and they are more in the 3 to 5 years of age in the children group. What's your suggestion or explanation for that?
You mean in the instance of the AE by age group?
Yes.
They are in a different age group, yes?
Yes.
Actually, we didn't find that there is two difference between the older age group and the young group. So, so my suggestion is that both the older group and the young group should also both should get the full vaccination on the inactive vaccination.
Yeah.
I didn't show
yeah. Oh. So there's also another question, which is for young children, 3 to 11 years, how would you comment on the adverse reaction compared with other pediatric vaccines such as MMR, chickenpox, or flu?
For the 3 to 17 years old, we saw the data showed a very good safety, but now we still, for the younger group, we have only the 2 doses of the vaccination. So I suggest that based on the data among the older group, so I suggest that the third dose for the children should get the third doses of the vaccines, and also for the other disease. For the other disease, I think for the EPI should continue to work well.
Yeah, generally speaking, the adverse effect is for COVID-19 vaccine is less or more than the EPI vaccines.
Yes, that's. I also think that is maybe the reason is the method of the data collection.
Yeah, I mean I have another question. We have seen that Chile, with a country with a population less than 20 million, and they have a national database of insurance. They can get the data, analyze almost the whole population for vaccination. China, we already delivered over 1.2 billion doses much more doses. We already vaccinated more than 1.2 billion people. Our data is so big. Each country is about average 50 million people. Do you see a possibility of using our database, the big data in China, to study the safety and for vaccines? rather than do a prospective cohort study. Is there a possibility to use, for example, in your province, in Yunnan province, it's about 50 million people around. Can you do a total survey with big data for
for the generally EPI, there is another system to collect the data. It's AEFI 7th system, but we didn't compare that our study with the AEFI the system.
Okay. Cool. In your study, do you also monitor the co-administration of other children vaccines? Is there impact on this study?
Sorry, that?
I mean, the children EPI program continues in the year for different vaccines. Do you consider the co-administration of other vaccines, their impact on this study?
I think maybe have some impact for this study, but for our study actually is designed by the Coronav and all the PI from the different province. Even they didn't attend the study. It's also the people should to get the vaccine of the even by the Kononovac or other COVID-19 vaccines. So I don't think that there is common impact for this study. However, we conduct a study in the research set. The research set means they also conduct other vaccine trial.
Okay, thank you, Dr. Liu, for your presentation. We are looking forward to the final analysis of the safety data, especially for children. Now I will introduce our last speaker, Dr. Yongjun Guo. He is from Sinovac biotech, and his presentation topic is update on the COVID-19 vaccine of Coronav for pediatrics group study. So that is an important study for very young children using the Coronav vaccine. Mr. Gao, please, the floor is yours. Can you share your slides?
Yes.
Yeah.
Yes, thank Dr. Shaw for the introduction. So it's my pleasure to share some evidence from Sinovac about the pediatric population of 2 doses of Coronav and also 3rd dose of Coronav. So I will mainly cover 3 topics. First, we'll review some data from phase 1, phase 2 clinical trial with 2 doses of Coronav among children and adolescents. Then we'll focus on evidence from the both doses of Coronav, and also have some interesting studies from other researchers in Turkey and Brazil about the safety of Coronavac. So first, this is a graph to show the design of phase 1, phase 2 clinical trial of two-dose Coronavac among children and adolescents in China. Basically, the interval between the first dose and second dose is 28 days. The study period is about 1 year. It started last year in October. So objective is to evaluate the safety and the tolerance of different dosage of vaccine in healthy population aged from 3 to 17 years old, and also to evaluate the immunogenicity of different dosages to determine appropriate dosage for further clinical trial. So this graph shows the basic design of phase 1, phase 2 clinical trial of two-dose Coronavac in children. So there are 3 age groups, 3 to 5 years old, 6 to 11 years old, 12 to 17 years old. And we have 2 dosages, low dosages and middle dosages. And also for phase 2 clinical trial, we have a placebo group. So totally, the phase 1, phase 2 enrolled about 550 volunteers. And the result of the safety is very well, because the overall incidence of adverse event is about 20 to 30. It's quite good, because if you compare with other vaccines, it's pretty normal. And most of the adverse reaction were grade 1, grade 2 in severity. Just a very adverse event. And except for injection site pain, no significant difference in the prevalence of other adverse reactions among the 3 different age groups. And the most common reaction were injection site pain and fever. So this is a result from 2 doses of Coronavac among children. And most importantly is that there's no serious adverse reaction related to the Coronavac. And also the result shows that different dosages of Coronavac are safe among all the 3 age groups. And for the immunogenicity, the overall positive rate for different age groups and also different dosage groups is good, because most of them are over 93%. For some groups, it's almost 100%, or the positive rate of the 2 doses of Coronavac. It also means that all groups of children after 2 doses of Coronavac has induced antibody against SARS-CoV-2. And if we come to the GMT of the middle group, middle dosage groups, that's 3 microgram groups, were significantly higher than that of lower dosage groups, that's 1.5 micrograms. So if we come to the those means the GMT and also the humoral the antibody levels, is clearly shows that 2 doses of Coronavac induced humoral response among children and adolescents aged 3 to 11 age groups. And for the different age groups, 3 to 5 years old, 6 to 11 years old, 12 to 17 years old, it also shows the similar trend. That means there's a good GMT levels to show that in different age groups, they all means 2 doses of Coronavac induce good immune response. So this is also a very solid result to back up the massive vaccination of 2 doses of Coronavac around the world. And also for the 2 doses of Coronavac, we have some result about persistence of immune response. So this graph shows that even after 3 months of 2 doses Coronavac, the positive rate is still about 86%. For GMT, 6 months after 2 doses of Coronavac, the GMT is still about 21, almost 22. So this is a result that shows that, and also many people focus on the persistence among the children. So the result shows very good too. And also for the immunogenicity among children and adolescents, we compare the result with to the adults and elderly. It also shows that the result, the antibody, antibody level or GMT in children and adolescents is a little bit higher than adult and elderly. So this means that when we think about the immunization schedule among children and adults, it should be a little different because there's a little stronger immune response among children if compared to adults and elderly. So this is another very important information when we think about the immunization schedule among children and adolescents. And also this is all a result about 2-dose Conovac among children and adolescents. So how about the 3rd dose? And also we know that some countries and regions have think about and also even practice a boost dose for children and adolescents. So what's the result about the 3rd dose of, we call it boost dose of Conovac among children and adolescents? So this is a result just from the children in the study of phase 2 clinical trial in Hebei, I mentioned a little earlier. So this study covers 346 children and adolescents. So we have 2 dosages among those children. One is low dosage is 1.5 microgram, and also a middle dosage is 3 microgram. So for the schedule, there are 2 different schedules. For the primary series is same for the group, for the different groups. The interval between the 1st and the 2nd dose is 28 days. But for the first dose of group 1, there are 10 months after 2nd dose. The interval between the 2nd dose and 3rd dose is 10 months. For group 2, they're a little longer, 12 months between the 2nd dose and the booster dose or 3rd dose. So based on this design, the results of safety shows that the overall incidence rate of adverse reaction is about 7.8%. It's quite low if we compare the result from phase 1, phase 2 of 2 doses of Conovac, and all adverse reaction were grade 1 or grade 2 in severity. So far, we don't identify serious adverse reaction during this study. Focus on 3rd dose or both doses of Conovac among children and adolescents. So the most common adverse reaction, just like the results from phase 1, phase 2, is injection site pain. It's very common when we conduct a clinical trial. So this is a basic picture of this both study clinical trial of Conovac among children. So now we come to the immunogenicity. So the result shows that very good result of the booster dose of Conovac. The result turned out that after a booster dose, there are more than 30-fold increase before after a 3rd dose compared with the before booster dose. So that means for children and adolescents among between 3 to 17 years, if they received a 3rd dose of both doses of Conovac, the antibody level or neutralizing antibody will increase 30-fold or 30 times before they got the 3rd dose. So for the positive rate, if we think it's, for the different groups and different, dosages, is all 100%. So that means all children in this clinical trial, they have, after 3rd dose of Conovac, they induced immune response, and also they have a higher, based on the 2 doses of Conovac, based on the immune memory, they have a higher and quick response. Compare the different level is more than 30 times. And if we compare the immune response between 2 doses of Conovac and the 3rd dose of Conovac, we use a peak time. For example, we use 20 days after 2nd dose and 20 days after 3rd dose and both doses. The peak level we compare, the result shows that they're about 5 times increase. That means based on 2 doses of Conovac, if children and adolescents got a 3rd dose of booster Conovac, then they can get a 5 times increase. That will help the children and adolescents to prevent the infection from Conovac virus or SARS-CoV-2 virus. So this is a result based on the original strain. How about the strain, now circulating in the real world, Omicron? So the result is also shows very good because the positive rate of neutralizing antibody were over 90% for 2 middle dosage groups. And also for the younger children, the children between 3 to 5 years old, the positive rate of neutralizing antibody was 100%. So we all know that children can be infected by SARS-CoV-2 virus or Omicron variant and can get sick. And some of them, just as Professor Kwan said, can get a very severe outcome, clinical outcome. So it's very important to think about or to use a 3rd dose of Conovac to prevent those serious illness. So the result here shows very clear that 3 doses or both doses of Conovac can help to prevent Omicron infection. And also the result shows that there's good cross-neutralization against Omicron strain of 3 doses of Conovac among children and adolescents. So this is the basis that can help us to build our strategy for children and adolescents against the Omicron infection. So this is a very important result to show that both doses of Conovac or 3rd dose of Conovac should be used to prevent the severe disease or severe clinical outcome of COVID-19 among children and adolescents. So this is what we want to share. We are talking about 3rd dose of Conovac among children and adolescents. And also some other interesting studies. It's very interesting to show that the Conovac is very safe among pediatric population. For example, this is a result. This is a study published or released by the clinical doctors in Turkey. The study is focused on the inflammatory rheumatic disease. So the result shows that there's no very severe adverse event after admission of a 2nd dose of Conovac. And also it's very interesting to show that the incidence of adverse reaction after mRNA vaccination is higher than inactivated vaccine. So it's very interesting and also evident to show that Conovac is very safe among children and adolescents. So another study is from Brazil. It's also very interesting because this is a study or this is a result among children between 7 months and 5 years. It's usually is not indication for the Conovac, but there's some we call that inadvertent vaccinating with Conovac. That means some people misused Conovac to the children between 7 months and 5 years. So the doctors in Brazil, they just collect the data and analysis the safety and also immunogenicity. It's very interesting to show that the result turned out that it's very safe for Conovac because there's no very serious adverse event reported. And also we thinking about the the serological result, it shows that there is a robust immune response to one dose of Conovac. Why one dose? Because it's misused, so one dose is enough. There's no second dose and third dose. At one dose, among children between 7 months and 5 months, the results turn out that it's very safe and also has a good, robust serological response. So this is a very interesting result of Conovac in Brazil. And also we have some report focused on mass vaccination among pediatric population. The result based on analysis between June and August 2021. The total doses is about 63 million doses of Conovac in mainland China. And totally, there are 1,779 individuals have AEFI reported. So the overall incidence of AEFI is only 2.8 per 100,000 doses. It's quite low or quite comparable to other vaccines used in China. And if we're talking about the adverse event of special interest, which are recommended by WHO that we should pay more attention whether is any of type of COVID-19 vaccines. So the total incidence of Conovac, the AESI of Conovac is about, it's very low, it's quite low, it's 0.041. And the severity of the reported AEFI, over 98% is non-serious AE, adverse reaction, adverse event, not reaction. So this result also shows that not only in clinical trial, a well-designed clinical trial, but also on the real world during a mass vaccination, two doses of Conovac shows very good safety profile. So, okay. Okay, and also we have another ongoing phase 3 clinical trial in 6 countries. So it's ongoing, but the preliminary results focused on safety has shown that the overall incidence of adverse reaction was similar to the results of phase 1, phase 2 clinical trial in China. So that the result shows that a good safety in healthy children and also in different races around the world. So, and also so far as much of 13, there have been 14 countries and regions around the world has approved EUA of Conovac in pediatric population, and more than 280 million doses have been administered among children and adolescents to prevent severe disease and deaths around the world caused by COVID-19. And so far, totally, there are 61 countries and regions around the world have granted Conovac EUA or conditional approval. So this is also a confidence to that Conovac has a good safety and also had good immunogenicity. That's why so many countries and regions has accepted Conovac to prevent as an important tool to prevent COVID-19 disease or to fight against the pandemic. So in summary, we see a favorable safety and immunogenicity of 2 doses of Conovac in phase 1, phase 2 trial, and also from the real world. And both doses or third dose of Conovac induce good immune response among children and adolescents, and also have a very good safety profile and good safety among patients with some specific disease like inflammatory disease, and among children between 6 months and 5 years, also is unfortunately, but it turned out that it's very safe and also has good immunogenicity. And so far, 14 countries and regions granted Conovac or conditional approval in pediatric population around the world. and 61 countries and regions or international organizations around the world also has granted Conovac EUA or conditional approval. Okay, thank you, Dr. Shaw. That's what we want to share.
Thank you, Dr. Gao, for your comprehensive presentation of the safety of Coronavac vaccine in the children. And there are two questions. The first one is whether there is any data concerning the cellular immunity induced by Coronavac, or if there are, how about the cellular immunity response to the Omicron variant?
Yes, we do have some evidence to show that 2 doses of Conovac has a good cellular immune response against Omicron, Delta, and also white type of coronavirus. It's another study from Chile. So based on phase 3 trial in Chile, the researchers select some volunteers. They conduct the analysis focused on cellular response of 2 doses of Conovac to see if there are good immune response against Omicron-strain. So the result shows that it's good. There's a good cross neutralization of 2 doses of Conovac against Omicron. So I can share the data if the audience is interested with them later.
Yeah. There's a second and third question is concerning the interval between the booster vaccination for children. So in your study, you have 2 groups. One is 10 months, another is 12 months. And the question is why with that time interval? Could that be given earlier?
Yes, we select 10 months and 12 months at the very beginning when we do the study design. It's because that we from our clinical trial, a previous clinical trial, it shows that the immune response among children and adults is a little stronger if compared to the adults and elderly people. So we think that it should, in the persistent immune response of children and among children and adults should be last longer. So that's why at the very beginning we select 10 months and 12 months. But it's a clinical trial. If we think about the real world, means the real world situation, when we think about the interval between third dose and second dose among children and adolescents, it should decide or determine based on the situation, especially epidemic situation in the country. For example, in the region of Hong Kong or in other countries, the interval has been shortened to 3 months or 5 months or even 3 months because they want to get a quick, robust immune response to prevent the Omicron virus. So also in our clinical trial, we use 10 months and 12 months. But when we think about the immunization schedule, especially when we we develop the national strategy, it should be based on the real world. It should be maybe shorten the interval between the second dose and the third dose or both doses of Conovac.
Yes, I agree. I mean, the research environment is different. Like in China, we have low risk for COVID-19. And in the maybe American, European, even Hong Kong, we have a high risk. And even though we have space and time to design a longer interval, we don't have the risk of the viral attack during this interval. But in the high risk area, they have to fill the gap for the maybe fourth and fifth waves of the COVID-19 variants. And there's so that's the last question is what is the estimated general efficacy of Coronavac in pediatric population according to the study?
Oh, yes, this is a very good question, because what we have done, because that is elaborate, is a well-designed clinical trial, but how about the performance in the real world? But based on our result of 2 doses of Conovac among adult and adolescent and elderly people, so we can expect that there will be a good performance of 2 doses of Conovac or 3 doses of Conovac among children and adolescents. So because the biological mechanism is a little similar, so when we talk about the effectiveness of the protection in the real world, it should be combine a lot of factors. It's not only the role of the vaccine. So we are very confident that 2 doses or 3 doses of Conovac will perform very well or had a good safety and immunogenicity among children and adolescents. So we need to work or collaborate with the government and also other organizations to work together to deliver the vaccine to children and also adolescents. Then we can see if there a good immunogenicity or a good effectiveness that of 2 doses or 3 doses of Conovac to prevent the disease. And also based on the results shared by Professor Rapro, it's very clear that we already have some evidence of 2 doses of Conovac can prevent severe disease or even death of among children and adolescents. So this is data from Chile, from the real world, and based on a very big cohort. So I am very confident that 2 doses or 3 doses of Conovac can help the world to fight against COVID-19, whether it's Omicron or other COVID-19 variant, to protect children and adolescents from severe disease and also from death, even death.
Yeah, thank you for your the discuss. And I would like to draw a conclusion for our today's symposium. I would like to thank 4 speakers to give a very comprehensive from children disease and to vaccine efficacy and also to vaccine safety data. And I mean, in the first 2 years up to now, the focus for vaccine, primary focus is on adult, especially for older people, age 70 and older, because they are the most vulnerable population for mortality cases. So we have to provide protection to them. But now the situation has been changed. As most older population for different countries has been already vaccinated and get booster dose, many of them. And also with Dr. Kwan's report for the multisystem inflammatory syndrome in children, and also more complications of children's neural system. And also children has less vaccine coverage, especially has not yet many children population have a booster dose. And our focus should be shifted also focus on children with vaccines. And we we are very glad to see the presentation today showed that the Coronavac and we can estimate the other inactivated vaccine have a very good safety profile in children. So that can provide us an opportunity for the future focus safe on children, using more, combining different vaccines and both the inactivated viral vector mRNA vaccine with based on data with a better efficacy and good safety vaccine for children. Thank you for all the participators for this symposium. We will continue focus on this area and organize future symposiums. Thank you again, Dr. Kwan, for your very important findings, the alarming, which can focus, I think, the world efforts on that specific syndrome. Thank you all. Thank you. Bye-bye.